All right, we can see your screen. Excellent. Just need, yeah, you're still on mute, but
I'm not hearing anything.
Hi. Yeah, this is the first case I wanted to show. Just a pretty case of metastatic pulmonary calcifications. Patient with end-stage renal disease on hemodialysis Monday, Wednesday, Friday. Otherwise, it's other cardiovascular comorbidities like HFrEF, aortic stenosis, status post TAVR. But yeah, just a really pretty picture of these like fluffy centrilobular nodular opacities, kind of upper lung predominant. Um, I think what was interesting about this case was just the rapid development of this. So this one was from this month, and then just a month ago is the screen left, and then this is from mid-February, and then you can't really appreciate the pulmonary calcifications as much. And it's just interesting this rapid development over 1 month and how it became like this. I'm not sure how often you guys see this rapid development of MPC.
so in my experience, it can, it can happen with like an acute illness or something, where you get acute disruption of calcium and phosphorus metabolism. I've seen it in patients with pancreatitis. I've seen it in patients, who have kind of chronic kidney disease who get an acute kidney disease on top of it. So that's one possibility. I don't know if there was anything in this patient's
What
history.
I was just thinking, we don't see, or at least I haven't seen a lot lately, and I don't know if there's better management of calcium and phosphate balance now, or if I'm just
I
not
think
seeing.
so, because we don't. I mean, I still see renal osteodystrophy, but not as much as I used to. Also, I think they're better at managing this, but who knows?
Yeah, that's a very nice
Yeah, it's a
case, though.
beautiful case.
Thank you. And this is the second case we have. Patient lung transplant for ILD. She had a retransplant in December due to some complications. What we wanted to show, um, so there's this kind of like narrowing of the left main pulmonary artery where the sutures are, and then this necrotic collection in the left lower lobe. And then we also see kind of like this abrupt cutoff of this left inferior pulmonary vein. So we were thinking in this post-transplant patient if this was potentially like a post-transplant complication, maybe some pulmonary infarct due to that narrowing of that pulmonary artery. Um, they did a BAL on this patient, and this ended up being mucor, this abscess in the right lower lobe. So
So it's kind of, yeah, it's just an interesting case because I think it's when this was being read initially, this was like a relatively, you know, short, shortly following the transplant. And so we saw those kind of areas of narrowing, and there was some suspicion of, could this be some sort of post-trans, like peri-anastomotic stenosis that's causing the problem? And it turned out to be like mucor. And of course, there you can see that the patient has all of this interlobular septal thickening, and so some of that could be primary graft dysfunction, or maybe, who knows, maybe there's some like fungal nodules mixed in there. So it was just a nice case of pulmonary infarct, and you can see in that left lower lobe, and if you put it into like a vascular window, come up. Or do we have the coronal actually? And let's go to that inferior pulmonary vein where it occludes. Go back. Yeah, so here you can see the left inferior pulmonary vein is just kind of cut off, and these patients are immunosuppressed, and so they're at higher risk for um, developing angio-invasive fungal infection. And so here we have that characteristic appearance where you have consolidation and you have kind of a centrally lucent area in this person with mucor.
So I'm presuming the patient was so it was a retransplant, but the patient was still immunosuppressed from the previous one, and
from
that's
the
because usually
previous,
you
right,
wouldn't see it. Yeah, you wouldn't see a opportunistic infection this early.
right. So interesting case.
Wow, very neat. All right, well,
Oh, that's
thanks
all
for
the cases we
sharing.
have. Thank you.
Great. Travis, you want to go?
Sure. Right, do you see my screen?
Yeah.
Okay. So this is a CT. This is also a lung transplant patient, and she was transplanted 15 some odd years ago for uh, pulmonary fibrosis, and I don't know any more than that if it was connective tissue disease or not, or if it was IPF. But she came in with hemoptysis, had this PE protocol CT, and in the left lower lobe, there's this thing, which is in a bronchus right next to the pulmonary artery. And I'll zoom in so you can see it. And then when you window, you can see that it looks like it's discrete from the pulmonary artery, and it's a little bit higher attenuation than the contrast in the pulmonary artery. And it's very, you know, discrete in its like disc shape to it. And her airways beyond that look okay, and her lungs otherwise are fine. She's had some bouts with periods of acute rejection in the past, but no real chronic disease. So this is credit to my fellow who saw this on call this weekend and correctly thought that this was probably an aspirated foreign body like a pill. You know, when I was first seeing this, when it was shown in our interesting case conference the other day, my thought was maybe there was some sort of pseudoaneurysm from a bronchial artery in the airway if they had done a bronch, especially in that lower lobe. Not that that's the typical location you go for a bronch, but then you can see when you window it, it really does look like it's a different attenuation. We didn't have a non-contrast study. She had a prior CT from several months ago, and you'll see there's nothing there in that airway in the left lower lobe. So this was new. The patient didn't recall having aspirated anything, but they took her to bronchoscopy, and I'll zoom in on this. And sure enough, this was a pill that was disintegrating, and it has caused an intense bronchitis in this area as well. And I thought these were really illustrative pictures from the bronchoscopy, which I will show you. And you can see all this whatever silver metallic looking material that's left over as they debride and recanalize that bronchus. And what's really interesting too, I think we've all heard of and are more familiar with pill esophagitis rather than pill bronchitis, but this patient was left with some raging inflammation in this airway. And this is presumably where the bleeding was from, and they did some cryotherapy and ablation. They brought her back 4 days later to do a repeat bronch. She's been on steroids and trying to cut down on the inflammation. You can still see there's some mucosal ulceration and irregularity there, but it's getting a little bit better. So I don't ever remember seeing a case of an airway inflammation this intense from a pill aspiration. Do any of you guys?
I think maybe it was David who showed, or I know I've seen a couple, but
Mhm.
potassium's another bad one. And then we had I think it was an iron pill that had caused a lot of problems.
And of course, we don't know what this one is, but the same interventional pulmonologist sent me this article that he had written up 10 plus years ago. And this was a alendronate pill, and same thing, it caused pretty profound tracheobronchitis, as they say here, that required a prolonged hospitalization.
Wow.
Yeah, so he's gonna see if he can figure out what medication it was and press her on it a little bit more. But I thought that was obviously a very good pickup and a good call to think that that was a pill.
Yeah.
All right, now I have to remember I've got a bunch of cases here, and I just have to figure out which ones. Let's see which order I want to go in here. Well, let me check this really quick. We'll go to this one. So this is a patient who you can see has a tissue expander in their left breast. They have a right breast implant as well, and had presented with a cough to an outside hospital. Their mastectomies had been 2 years ago, and they were considered prophylactic mastectomies for DCIS. The patient wasn't being followed with an oncologist, and so this was done at the outside, and they noted this fairly focal abnormality in the right lower lobe, and thought it was most likely pneumonia, which I think is not at all unreasonable. You'll see, though, the lungs do look a little bit busier than that. I think as you look in the retrocardiac clear space, even over the spine, it looks a little bit more nodular in some places. So she didn't get any better with her dry cough. She wasn't really having any profound infectious symptoms, and underwent this CT, which I saw. And as you'll see here, some of this is smooth septal thickening, but then in other areas, you see quite a bit of peribronchial cuffing or bronchial wall thickening, and more discrete nodules, and some nodular areas of septal thickening, and more just confluent mass-like areas of consolidation in both lower lobes. And unfortunately, I called the clinician, and she ended up undergoing a bronchoscopic biopsy, and this was all adenocarcinoma recurrent from her breast cancer. And so I was kind of curious, and I was talking to one of my colleagues who's a breast imager, what's the risk? Because like, why wasn't this lady being followed, since it was just DCIS? And, you know, she told me she thought like 20% of the time DCIS comes back with metastatic disease. And that was just a ballpark. I didn't realize it was that high. And I don't know the circumstances behind her not being followed. But pretty characteristic look of lymphangitic carcinomatosis, and especially if the patient's not really that ill, which this patient wasn't, then there's not really much of a diff. And obviously there's pleural effusions, but the left heart looks completely normal. All right, and that leads me, let me find the companion to that then, which is going to be this one. And this case is just crazy. Actually, I'll start with a radiograph here as well. And you can see fairly indistinct costal margins here, maybe a little bit of septal thickening, generalized increased haze in the lower lobes. And in the acute setting, you might think there's some edema, but the fissures are a little thick, sure. So maybe edema and small effusions. But this is what the CT looked like. And this, when this is an old case. This case is 15 years old, which is kind of why it's crazy, because the patient's still alive when I tell you what they have. It reminds me of, a few of the cases of Niemann-Pick disease I've seen, or some sort of deposition. This is not Niemann-Pick. They did a transbronchial biopsy and a bone marrow biopsy back at this time, and you can see there's just essentially at least septal thickening, if not full-on crazy paving. Yes, there's increased ground glass opacity everywhere. And this all turned out to be light chain amyloid. And so this is, I guess you would consider the alveolar septal pattern of amyloid. But they did a bone marrow biopsy and had AL amyloidosis. So this patient was treated with combination therapy of whatever the, I've got it here in the report. They're in remission, and for 15 years now, they've been in remission. And this is what they're left with. And they're fairly asymptomatic from a respiratory standpoint. They do have some degree of chronic renal disease and some chronic reduced lung function, but it's not really inhibiting their life. And you can see they have some areas of either calcium or bone deposition in the lower lobes, but much of that has improved. And they were on, so they were on chemo plus Velcade, whatever the newer version of thalidomide is, and steroids. But yeah, 15 years is pretty impressive for this. So, and this is maybe the most, one of the most dramatic cases of light chain, like AL amyloid I've seen in the lungs. All right, and then we'll go Oops. I've been on radiographs a lot lately, so we've had some interesting radiographs come in, as there always are if you're on the lookout for them. But this was a patient that came in, and the overnight resident gets credit for this one for recognizing, and we had a comparison, but recognizing the atrial lead is not in the atrium, and I'll pull up the comparison. I believe let's see if it's that one. Yeah. So there you can see where it should be, and correctly pointed out too that the generator has rotated as well. So this patient was woken up during the middle of the night with thumping in her right abdomen. So pretty classic for stimulation of her right phrenic nerve and her right hemidiaphragm. And so they went and revised this, put that right atrial lead back in. Now, they didn't say if they sutured the generator back into the pocket or if they had to reduce the size of the pocket just to prevent this from flipping and rotating again, but they have reimplanted it in the expected location. So a very typical look of Twiddler syndrome with the history to go with it, with the thumping in the abdomen. Jeff, how many cases do you have?
Just 3 or 4. Take your time.
Okay, I'll just keep going then. Not that I need to start with the lateral on this. This is a 24-year-old former college athlete who has no history and came into the ER with worsening, crippling, and debilitating abdominal pain. And I think I always find the lateral to be helpful with pneumoperitoneum. I mean, it's not a diagnostic dilemma in this case. You can even see it looks like there's an air fluid level in the peritoneal cavity, and here on the PA view as well. You can see stomach bubble being outlined, and then a large volume of air, a little continuous diaphragm sign here. And she underwent an abdomen pelvis CT. So the interesting thing in her is this is a large volume of air, and you can see right here and you can imagine where you catch that on the upper portion of an abdomen, even on a chest CT. But she had a huge gastric ulcer, which was the culprit. She ended up undergoing a partial gastrectomy. She was not on NSAIDs, not a drug user, no other risk factors for gastric ulcer. The pathology was just ulcer, NOS, no underlying pathology, no malignancy or other things to predispose her to gastric ulcer. So she perforated, had like pyogenic peritonitis and just dirty peritoneal fluid, no surprise. But I don't know. It's just a bad luck, I guess, for her. No NSAID use, like I
Wow.
said, but just
Yeah, I agree that lateral is so helpful
another.
sometimes because you can distinguish it from stomach, bowel, fake outs from the lung.
Yeah, I for any trainees on here or faculty that like getting better at the lateral, there's still days where I will, if when we get caught up, we'll start with laterals when I'm looking just to kind of, you know, change up the rhythm and remove some of the monotony of just having to go through a couple hundred films. But that's how I was trained as a fellow and challenged to just look at the lateral first and see how much I could diagnose based on it. All right, let's see. All right, so Jeff, here's a new bug for me. We'll see if you've heard of this one. And this again is just a very nice radiograph to look at in terms of kind of tells the whole story. And actually, this is the follow-up radiograph. Let me put the first one up. Oh, come on. So this patient had presented to an outside hospital. I'll just show the PA view here. But you can see on the left side they have a hydropneumothorax. So they had an empyema drained at an outside hospital, and apparently they were unhappy with the care they were getting, so they left AMA and came here. And you can see at this point there's air. There's no chest tubes left at this point, but it's a loculated hydropneumothorax. You suspect there's probably trapped lung here, probably a bronchopleural fistula. And you can kind of tell the whole story that this patient presumptively had an aspiration pneumonia because they've got, as you can see here, this huge pool of contrast. It's right behind the trachea in a good location for a Zenker diverticulum, which is what this is. And so this, and I'll show you. And so that's what happened at the outside hospital. And there you can see this is retained from an old swallow study, presumably that they'd had at the outside hospital, but just nasty infectious pleural space. Now, at least several airways that are communicating with that space. And so they've since undergone decortication for this. But this grew two bugs, well, Strep intermedius one, but Parvomonas micra, which I'd never heard of, but is an oropharyngeal flora, and this is from the ID note. You ever heard of that one? Anybody?
No.
I figure maybe David has, but nobody, it's either you or David, or it's nobody, since you guys like all these weird bugs. But I think I've never seen a Zenker's diverticulum on a radiograph containing this much contrast, but it kind of tells the whole story. I mean, he had poor dentition too, but clearly this would place him at increased risk of aspiration, or presumably. So another good lateral radiograph. What do you think?
That's great. Yep, you can make the whole diagnosis except for the bug on the radiograph.
Yeah, right. Well, but even that, you could say it's probably polymicrobial, or probably oral,
Right.
or gastric, or some sort of anaerobe that's causing a necrotizing pneumonia.
Yeah.
So yeah, but you're right. Except for the very exact one, you won't make the diagnosis. But everything else you can tell in the story, and that's also why it's fun to sit back and again, for trainees on there, when you look at a radiograph, just try and tell as much of the story as you can. Before you don't just focus on every one little thing, look at the whole picture first. And so this is one of those patients too that this is something we see on occasion. This guy presented, he's got a pick in for an abscess. The abscess happens to be intracranial. And the question is, why would somebody who's otherwise healthy have an intracranial abscess? And the answer is right here. So see a vessel left of midline. This is a left superior vena cava. There's no bridging and nominate vein. It's draining the left SV, or the left IJ, and the left subclavian vein. And as we should always follow it, and this was noted on the CT, picked up prospectively, but this does not drain where it should, bleeding into the coronary sinus and into the right atrium. It goes directly into the left atrium. And I don't know, I've seen a dozen or more of these now. It's been reported that up to 5% of left SVCs drain into the left atrium. I don't know where that number comes from, and I think that may be a little overestimation, because I don't think we see it that often. But certainly, if they have other associated congenital heart disease, that number may be higher. This patient also has, which is harder to see, they have right here an inferior sinus venosus ASD, and you can see that right there. And so they had both of those, and both repaired by surgery. So they redirected the left SVC, and then they did a patch closure. But of course, this is a right to left shunt, which explains why the patient ended up with an abscess in their brain, didn't go to the lungs to filter out whatever bugs, and end up just in the lung. It ended up in the brain instead. So yeah, this is, whenever you see a left SVC, you always have to make sure it drains into the superior, or into the right atrium via the coronary sinus, rather than directly into the left atrium like this. All right, and then let's see, we've got a couple other interesting cardiac ones. This is a patient who's had a prior brain aneurysm. They're young, they're 20, and you can see this is not a normal ascending aorta. And if I look at it, let's see if I do an MPR and coronal, you'll see that the sinotubular junction is not quite as effaced as you might see with Marfan's. This patient doesn't have Marfan syndrome, but they clearly have a little bit of a distorted musculoskeletal system in their chest. And you can see they have, a strange looking, well, the arch vessels just look a little weird in the coronal plane. But anyway, this is a patient who has an ACTA2, ACTA2 mutation, which I've only seen a couple of cases of. I was talking to my friend Nick Burris at Michigan, who has a whole collection of genetic aortopathies, and he said they've probably seen 5 or 10 of these, but it's another one of these just severe vascular aortopathies where patients can get, obviously a lot of these patients present with this dissection. This was picked up just because he had already presented with a cerebral artery aneurysm, but high association with all sorts of large vessel aortopathy type things like dissection, aneurysm, and such. So, but just add this one to the collection, the ACTA 2. And then, let me see, I think this is the last one I have. And this one, I'll just show it on the non-con first, just because, you know, most of our CTs are done non-con. This is not, but it is worth always, looking at the heart and looking at the mediastinum, especially, or just looking at the heart and getting a sense of what normal is, and realizing when something like that, there's the aorta, and something just looks way too big right there. And you can see right atrium down here, and that should pique your interest if you don't have contrast. But of course, if you do have contrast, then it makes it much easier to see. But uh, this, as you can see here, so right, left coronaries come off the appropriate locations. This patient's never had surgery. And this is just a huge, over 7 centimeter sinus of Valsalva aneurysm of the left, or of the non-coronary cusp, or non-coronary sinus. You can see how much mass effect it's exerting on the left atrium. And I can, I'll tell you that, and many of you may have seen this before too, stuff like this can be easily overlooked if people aren't familiar with looking at the heart, and they just are scrolling through and think this is part of the atrium and aren't explicitly looking for it. Now, this was known. This patient had a murmur, had some left ventricular functional issues, and it's because they have just 3+ regurgitation as a result of this thing. But look how big that is when you do just a coronal reformat. And so one of the reasons this is somewhat exceptional is that whatever 85–90% of sinus of Valsalva aneurysms are typically off the right coronary sinus. Maybe I've seen 1 or 2 off the left and non, but certainly not one this big. And you can imagine how if this continued to enlarge and it ruptured, he could end up, at best, result with a high output fistula to the right heart, and at worst result with just spontaneous death from hemopericardium. So, and this was repaired. They were able to resuspend his valve. The valve leaflets were competent. It was just how large this was distorting and resulting in this eccentric aortic regurgitation.
Wow.
So,
It almost looks like an accessory atrium. All right.
yep. Oh, I know. And that's why it can easily be overlooked if you're not, consciously looking at the heart and aren't familiar with what normal structure should look like.
All
All
right.
right, Jeff.
Thanks. All right, I got a handful of just a few cases here. Let me start with this one. So Travis, this will be one I'm curious about your thoughts are. So this is a 8-month-old with some congenital heart stuff, but the real issue is with the aorta, and we were having a discussion about what this might be. So you can see the arch is on the right, and there's an aberrant vessel, looks like a left subclavian, but you'll notice it gives rise to both the left common carotid and the left subclavian artery. And then there's this little, looks like a ductus here on the left that is open. So it is a ring. And so the cardiologists were saying that this is some rare anomaly with this carotid, but I think this is just a double arch with the atretic segment being here as opposed to the usual place. So you imagine the Edwards model, because when you come up here, you get that nice 4-vessel sign, right? The symmetry of the
Yep.
branching. So I think this is just a double arch atretic segment. Just usually we see it broken here or here, but not with the carotid on the distal side.
Yeah.
But,
I mean, regardless, it's a ring because of the left ligamentum there, or
right.
that left ductus. I have shown a case of what I just thought in an adult was an aberrant left brachiocephalic artery, and again, it all falls in line with the Edwards double arch model, where you either have complete regression between the carotids, and you end up with a
Mm-hmm.
left brachiocephalic artery, or you have, aberrant left brachiocephalic artery, or you have a cord there that we don't see. I'd be curious
Yeah.
if they're going to go and operate on this, if they find a fibrous portion of a double arch or not, just because there
Yeah.
isn't a lot of mass effect anteriorly.
No, yeah, you don't
That's
see,
the only
again, you
thing.
don't
Yeah.
see anything there. But you got all this nice thymic tissue
Yeah.
here that may be acting as a cushion.
Yep.
And then there's this funny membrane
Sure.
here in the left atrium, trying to be like a core
Yeah. Kind
triatriatum
of.
there.
Yeah. Or just like I don't know, in a kid that's awfully big, like a atrial septal pouch like we see in adults. I don't know.
Yeah,
But you're right. That's kind of more of a core triatriatum.
yeah. Yeah, this is more academic, but it's kind of cool because we
Yeah.
don't see this
Yeah.
pattern very often. So,
But
okay, so
in
that was
this,
one.
but this also,
Okay.
well, that's also a good illustration of if the ligamentum regresses, or sorry, if the ductus closes and regresses, but also that your aberrant portion there gets pretty narrow right next to the ligamentum. If the whole
Right here.
thing regressed, then it becomes an isolated, left brachiocephalic artery, which
Mm-hmm.
kind of shows how that can happen. You know,
Right,
that's interesting.
right. All right. This is kind of a cool case. So this is a guy who had a double lung transplant, and you can see is on ECMO. Lungs don't look so great, has an open chest. But I'm going to point out so this is central VA ECMO. So this here is an aortic cannula. This is the venous cannula in the right atrium. But there's a third cannula here that actually goes into the pulmonary artery. So this is called a pulmonary artery vent. And they do this in this particular patient. I was asking the thoracic surgeon about this, who does a lot of ECMO, because I know I found a few things in the literature, but I didn't understand fully why they did it. So he had severe pulmonary hypertension, and so they do this to sort of decompress the pulmonary circulation. So these two cannulae pull blood out, and it's reinserted back through the pulmonary artery. I mean, sorry, the aorta here. And you can imagine with these edematous lungs that the right ventricle is not happy. Now this became kind of interesting because they were worried about a couple things. First, they were worried about the venous anastomoses, that what's going on, because his grafts are not working. And then so getting doing a standard PE study is a little bit tricky, because you're pulling all the blood off the pulmonary artery as much as you can. So if you give a venous injection, when the blood gets into the main PA, this cannula here is going to pull it right off. You can see there's that cannula. There's even some contrast in. So that's the PA cannula. Here is the right atrial cannula, and then the aortic cannula is up here. That's that superior one. So with this one, so it took a little bit of stuff because they didn't want to clamp any of the ECMO units. We usually don't clamp our VA ECMOs, but you can see there's the anastomosis of the left pulmonary artery. The right pulmonary looks good. But you can see right here you start losing perfusion to the upper lobe there. A lot of smoke artifact in the upper lobes. But we were fortunate enough to get we're trying to get to the veins here, and you can see there's hardly any, if any, contrast in the veins. We ended up doing another scan a different day and finally got to see it, and the veins are open, but the left atrium is tiny. So these lungs are just really heavy, wet, and with very little forward flow and high pressures. Contrast is getting in there, and it just kind of fades out there. But it's these ECMO cases are tricky, and there's some good papers out there on like how to time these and stuff. So normally we time off the left atrium for our pulmonary artery studies, but we can time off the aorta too to get a little bit more of a delay. We also did an abdomen, so we added on just a 60 seconds. So eventually we ended up getting but this one just shows where you have trouble. There's just not much forward flow, and then the venous return to the heart is so small. So in this case, we're on the earlier side, but there's already contrast in the aorta because it's coming back into the ECMO unit, into the aorta. So there's nothing in the left heart there. So I don't know. I always find these kind of a challenge to work through. Luckily, this situation doesn't come up. Now, why his grafts aren't working is unclear. I don't know if this is some kind of hyperacute rejection or what. He's too fragile to even do anything with. But they recently cleaned out the chest wall a little bit and took a little wedge of lung. So hopefully, maybe it'll show something of use on the biopsy. But Travis, have you ever seen one of these PA vents before?
Not on CT. And
Yeah,
hmm,
yeah. I found a
we
few articles
we
on
often have
that's what they.
we often have these patients that are on ECMO and RVADs and all sorts of combos that.
Mhm.
But yeah, I think that's a new one for me.
All right, so this is an old case I dug up, and I apologize if I've shown it before, but if it has, it's been a long time. So this guy had a lung transplant, so I went back to his pre-transplant imaging, and you can see he's got this just dense consolidation in his lungs. This kind of almost looks like pleural parenchymal thickening here, distortion, volume loss. He's on oxygen, and here's his pre-transplant CT. I think this is the right one. Yes, pre-transplant CT scan here, and you can see he's got this again dense consolidation with traction bronchiectasis. And if you look around the consolidation, it's hard to see, but there are some small nodules mixed in there, but not a ton of them. But as I go lower, you'll see there's again clustered little nodules there. And we go down, you start seeing some more nodules, and they're in a perilymphatic distribution. If we look at his mediastinum, I think another patient's image has got mixed in here. You can see he's got some mildly enlarged nodes, but really no calcium or much to say about him. And there's some calcifications in this area of consolidation, and it's a little bit dense. You see this just a little bit denser than this effusion, and almost iso to skeletal muscle. So it kind of looks sarcoid-like, but when you get this guy's history, he worked for a long time as a marble polisher. So lots of dust, and uh, this is a really probably one of the most horrific cases of silicosis I've seen. It's just interesting how that there's a lot of progressive massive fibrosis, but really you don't see too much of the residual nodules. Usually you see that, and for some reason he didn't develop calcium in his lymph nodes, and it may just be this was very high dose over a relatively short period of time. Um, but the dense consolidation is probably from the buildup of mineral in the lung. And this was confirmed on his explant that this was all silicosis. So just a really bad silicosis that kind of looks like sarcoid or even PPFE or something like that.
Wow.
Alrighty.
So marble polishing, what exactly does that entail? And is it like true
Um,
marble, or is this more Caesar stone and some of these other synthetic, like high silica
that's a good,
substances?
that is a good, that is a very good question. I do not have the details because I had,
Okay.
a lot of times they're seen elsewhere and then transferred to our institution for transplant. But it'd be
Sure.
something
Yeah,
interesting
I
to
don't.
know more about.
Yeah, I just didn't know if that was like, if it's almost like sandblasting, genes, or one of these things that he's just doing on an industrial scale where there's just tons of dust and what it's from.
Yeah, I
Hmm.
suspect it's like these countertops, and it probably is not all just marble. It's probably a mix of granite, marble, and other, stone-based things. And I suspect there's a lot of dust from the buffers, and I don't know if they sandblast. I don't think they sandblast it, but I think there's just it's this very fine dust. But I suspect it's the same as the countertops that we've been seeing, the manufactured stone. I'll see if I can find some more going through it, but it's all like just combing through a bunch of outside records can be challenging, especially when they're many years old. All right, this last case, my colleague Daniela shared with me. This is just kind of cool. You can see this chest wall is not normal. There's all this like nodular soft tissue with all these calcifications in it. And what's kind of cool though is you'll notice it stops at midline. It's confined only to the left hemithorax. And so, if you've seen one of these before, you know where I'm going with this. These little calcifications are phleboliths, and this is just a giant vascular malformation. He's had multiple treatments for it. I grabbed one sequence from an MR, just showing you the actual extent of this. So this is a T2 fat sat, but you can see just how much all the little channels of this thing, and you can see it right here, some supply coming into the internal mammary system, and it even extended into the mediastinum. What's cool though is it stops halfway, and I don't know why that is. He didn't have any other syndrome or something, where they can get them on one side of the body, but it was kind of a neat one. But once you've seen these with the um, Fleableist, you kind of recognize these, and they can be supplied from a variety of places there. So that is that. All right, well, those are my cases, so we'll stop there.